Good morning, PLA team. I'm Dr. Barrow. I'm introducing the BCMA presenting on medical marijuana and the responsible healthcare. Next, please. We have a disclaimer suggested by the FMA so we can receive CME credit for the presentations. You can go online and read the details. Thanks. Next, please. Obviously, due to time constraint, I only have 2 minutes.
No, you can keep going. You have 15 minutes. You don't have 2 minutes.
No, I know, but my presentation is only 2 minutes.
Okay.
We won't have an exhaustive dissertation on all the slides, but they will be available, I believe, Karen, for review if anyone wants more details about the presentation, because it's a very extensive presentation. Next, please. Here's the DCMA team, myself, Jeffrey, Jorge, Violina, Jolie, Smith, and our counselor, Jose, and Rafael Fernandez. So we all contributed to that excellent presentation. Next, please. Essentially, the project rationally is primum non no sharing, do no harm. A clinician must inform himself or herself about the pros and cons of any treatment it offers. It also shows the benefits for the sick and the benefits, all the measures that can be applied to help cure or alleviate a certain medical problem. Next, please. We have here this unfortunate physicians who appears to be rather unconcerned, kind of uneducated or dismissive about what the patient is asking him to offer to her. Next, please. When we look at medical marijuana, there is a growing body of evidence that medical marijuana can help in specific medical situations. Reminder that medical marijuana is allowed in the state of Florida. Next, please. Here's a chart from the Florida Board of Medicine 2021 annual physician review. It shows that in 2017, when the constitutional amendment was adopted, there were 54,000 legally users of medical marijuana. Now in 2021, we are 665,000. There's no way that physician can completely ignore the medical marijuana field. Next, please. So essentially, the DCMA PLA project will initially focus on 2 essential components. We want to provide education through high quality and well-vetted healthcare knowledge to all our providers. And second of all, during our FMA meeting, we want to present to the business meeting the best current scientific and legal parameters that impact physician practice and patient care dealing with medical marijuana. Next, Julie is going to take over and present the body of the discussion.
Thank you, Dr. Barrow. Good morning, everybody. So after our information gathering, we decided that we thought that we and all physicians needed more information. And that's how we came up with our project objectives, to further develop the resolutions submitted to the Florida Medical Association to change some of the policies that are preventing ongoing research and education on the integrated use of medical marijuana as a part of the treatment protocol for some patients, to recommend the development of additional educational programming that would provide greater understanding of the legitimate uses, and to encourage organized medicine through the DCMA to promote the change in policy and develop the educational programs, both CME and non-CME, necessary to fulfill these goals. You know, discussing marijuana is a politically charged and complicated subject, and we realize that, and it frequently brings skepticism just by its associations rather than by its realities. And for just a moment, or whatever's left of our 12 minutes, I ask you to sit with an open, unbiased mind so we can share the importance of our effort to educate physician colleagues and ultimately our patients. Because after all, how can uneducated physicians properly inform and treat their patients? This concerns understanding the supporting science and evolving laws. It should be emphasized that only when used in a responsibly educated manner Better physician oversights results in better patient outcomes. Bottom line, please make no mistake, our group is not here to advocate for or against the use of medical marijuana. I want to make that very clear. We are here only to advocate for education about its uses and Florida's legislation. Next slide, please. So one of the most recent pieces of literature is the FSU survey on medical marijuana in Florida. This was a PhD thesis project from the FSU College of Nursing. It was a web-based survey questionnaire, and a link was sent to almost 11,000 providers. And of those 11,000 providers, there was 561 who actually participated in the study. It was a 26-question survey. And it's important because this is the first study to report a knowledge deficit in Florida providers regarding medical marijuana. Based on this survey, our group decided it was important for us to poll our own population. We constructed a similar survey, sent it out to approximately 2,000 physicians in Miami-Dade County, and our study focused on a more specific healthcare provider population representing just South Florida. And our study reconfirmed the survey data and the conclusions that were collected by FSU. Next slide, please. So here are some of the results from the study. Only 47% of the physicians knew which conditions qualified a patient to receive medical marijuana authorizations. We did a little better in the next category. 2/3 of us knew what medical marijuana treatment centers were able to provide. But a significant finding was when providers were asked if they had access to the medical marijuana authorization registry. Out of 521 providers, only 74, so a measly 13%, said yes. And of those 74, only 20 said that they had actually checked it. That's only 3.6% that have actually gone to the registry and accessed it. And it's important for medical providers to realize that they have this access and to use it, because some of their patients, the medications that they're already using may have a synergistic or other effect when using medical marijuana. An additional finding, which isn't shown here on our slide, was when providers in Florida were asked if they had ever taken a CME on medical marijuana. Of the 483 respondents, only 1/3 said they had. And many of these courses may or may not meet AMA and PRA standards for CME credit. The courses may or may not have had any medical or clinical relevance or any information on the legal implications if the courses were provided by industry. Okay, so we think it's important that these courses are provided by someone from the medical field using evidence-based data. And the bottom line is, embarrassingly, the state of Florida has poorly educated physicians regarding medical marijuana. We received failing grades. Next slide, please. The other part of the FSU survey talked about the attitude of providers, and they gave 11 different statements with open-ended responses. And some of these statements related to training for medical marijuana being incorporated into healthcare professional educating. A resounding 82% of participants strongly agreed with that statement, and another 84% of participants strongly or somewhat agreed that all medical providers should receive education about medical marijuana. On the other hand, we need to recognize providers did express a concern for the inappropriate and recreational utilization of medical marijuana, and others cited safety concerns because there's no clear standards for dosing and possible adverse effects. So I wanted to address that. Again, we find a recurring theme: doctors requesting more knowledge. And as far as the inappropriate and recreational utilization, the reality is that the amount of THC in a standard joint was about 5 milligrams. And now an individual today, using today's concentrated varietals with the increased use, could be consuming as much as 300 milligrams per day. So yes, we absolutely need to know more about the safe and effective dosing of medical marijuana, and this requires research. But clearly, medical marijuana is more potent than ever. Some studies have shown that marijuana with a THC concentration of 10% or less, microdosing it's called, can provide relief for the neuropathic pain, the pain of HIV and AIDS, multiple sclerosis, post-traumatic surgical pain. The only area where dosing might need to be a little bit higher is the exception of cancer pain, which needs to be higher dose. Next slide, please. So our results are summarized in the next 3 slides, and I'm not going to go over them in detail just because they are available to you later. But they mirror what we saw in the FSU studies. 39% of us felt that we were well informed, 43% moderately informed. Talking about is medical marijuana legal prior to taking the survey? 91% of us knew that. So next slide, please. Continuing on, would you recommend medical marijuana or cannabis if possible? Almost half of us said that they would. And then do you treat patients? About 2/3 of us said no, we're not. Next slide, please. So if you continue to look at our questions, we really did mirror the answers from FSU. And what we decided was that the results of our study showed that patients deserve knowledgeable providers. Providers should lack bias. The risks and benefits, just like any other treatment that a physician would suggest, should be explained to the patients. And we need to get education out to the providers. Next slide, please. So based on the 2 surveys analyzed, there's an overall lack of knowledge and reliable research that physicians can utilize to make informed clinical decisions using the benefits of harm and medical marijuana. We need to further clarify the qualifying conditions, and there's a need to review the policies and regulations concerning medical marijuana here in our state of Florida. Next slide, please. So finally, the conclusions that we came up with from our project and our study is that we need to develop an educational program for DCMA members and for health providers in general to enhance the knowledge about the general topic of medical marijuana. We need to promote research to further develop the authorization guidelines and the standards of care for us to go by regarding medical marijuana. And finally, we need to promote changes in policies and laws and regulations regarding the medicalization of medical marijuana. Thank you for your time. I'm going to hand this over to Dr. Jeff Block.
All right. Well, thank you very much, both Dr. Barreau, Dr. Cantor. This is obviously a team effort. Everybody participated. The recommendations that you see here as 4 bullet points were essentially covered in the materials that both my predecessors mentioned. But the key message through this is, in fact, that evidence-based medical cannabis physicians should emphasize physician education and public health awareness. This is, in fact, the theme of the resolution that we'll be presenting the end of this month at the FMA's annual meeting. The reason this is important, and these are the scales of justice, is that the obvious confounders derive in that we have licenses as medical physicians, both as physicians in the state as 1 license, and then our Drug Enforcement Administration license, a federal license, which is our ability and privilege to prescribe medications. That's our tool bag. So in fact, many physicians are not likely to want to venture into this space with seemingly any constraints or anything threatening their DEA license. The fact is, though, a physician and patient's communications have been shown by the Supreme Court to be confidential, and these kinds of ways that we operate within the state of Florida under Florida's guidelines are still essential to appreciate the law's differences. The emphasis on high quality education is paramount, because in Julie's slides, when she talked about how many of the education comments were not necessarily CME approved, it's because we need to be cautious when industry itself is providing information for the physicians to be facilitators of patient access. So we've been here before. This is from about 15 years ago, when unfortunately here in South Florida, to a certain extent, we had very loose parameters on even what defines a pain clinic. And the Florida Medical Association was very helpful in promulgating legislation that gave us what that definition of a pain center truly is, so it could not be exploited as it was back then. Additionally, those were the days of computer access and data documentation. We have ways now of tracking not only which physicians are authorizing, but to keep patients from going doctor shopping that was popular years ago, and unfortunately through what was derived through Florida, causing the deaths from overdoses, not only to citizen patients in Florida, but up and down the East Coast. So one of the other elements that's inextricably connected with cannabis has always been tobacco. And even though a commercial company, Juul, promulgated vaporizing as a means of withdrawal from smoking cigarettes, we know now that kids get this. Shortly before COVID, any of you remember, we were having to deal with vaping deaths, and these were actually from contaminants that black market oils had in them. And very powerful news reports nightly came about when kids in particular were vaporizing contaminated cannabis products. We could do better. We learned from opioids what happens when we put certain reliable constraints on products. Pregnancy and smoking is not good. We know this because whether tobacco or cannabis, the smoking itself robs the blood of oxygen and has direct implications for fetal weight and viability. So this slide in particular likely shows a marijuana joint. This is one of the relative contraindications against use. However, in certain cultures, very dilute teas are used with cannabis products in order to restore during first trimester intractable vomiting that happens and afflicts some women during early pregnancy, ways that they could mitigate some of the nausea and vomiting and at the same time restore fluid loads to perhaps save from a spontaneous abortion from lack of fluids. So what's a physician to do? We need to balance, in a sense, the reality that there are no longer, as Carmel mentioned, 50 or so thousand patients. Once THC was available, now we have 3/4 or 2/3 of a million Florida citizen patients who have access to this, which means this impacts all physicians' practices that are currently practicing in Florida, not simply only the physicians who are authorizing patients. And the key here is that hyperbole in this space runs rampant. Not only hyperbole that patients may have misunderstandings, but as we found out from our surveys, the physicians, our physician colleagues themselves may not truly understand the details. It's a complicated issue. We have not been able to go into the great detail, but as an overriding theme, I just wanted to inform us that a temptation indulgence, if we're going to consider that of a traditional way that public may have regarded cannabis, it's an indulgence, but it offers choices. And in the same theme as the genie that comes out of the lamp and offers someone 3 wishes. Those first 2 wishes are the ones that sort of suck you in. The third one's that got you. So in fact, then with that temptation's indulgence, we get choices that actually caution us to be careful for what we wish for, because the science and reason behind this really do matter. So thank you very much for listening. I'm happy to entertain some questions and answers. And this is our chance to thank the PLA for the opportunity to present this and advance this, hopefully, as a resolution at the FMA's next annual business meeting.
Does anybody have any questions? I know I said we do them at the end on the agenda, but I think it's fine if we want to let people ask a question now if there's something that's burning and they don't want to forget.
No questions, only a comment. Congratulations to you all for presenting something that was by design left out of our core curriculum in medical school. And I know Jeff and I enjoyed having, who at that time was the chairman of the National Board of Medical Examiners for the United States, who wrote the pharmacology test that we all took as physicians as our professor of pharmacology. And he barely even spoke of it because of the political sewer cover that was left over this particular hot item. It's politically charged. It's basically almost trying to convert somebody from one religion to another to discuss medical marijuana. I did write an article about this. I think I was the only physician in Florida to have published why the legalization of medical marijuana should be done. I did that about 4 years ago. It was published in the Broward County Medical Association Record magazine. So kudos to you all. This is very, very well done. I really appreciate the fact that you did this.
And I'd like to add something to what Dr. Behrens was saying, since we were classmates. About 5 years ago, I had the honor of being the president of our alumni association for the medical school, and entrusted to give the oath of medicine, trying to tell our new doctors right from wrong. On my board were the deans from the medical school, including the deans of education, that they themselves recognize the importance of this curricula. However, when trying to advance it to become part of the current curricula, there's a real conundrum that happens, strangely enough, because of the federal disposition saying that this is a substance that by definition has no known medical use. The problem is that it is not asked about on the national board exams that all physicians take upon being conferred their MDs. No one in any state in the country can get a medical license until they go through that national board exam. And you can imagine then that because it's a national board exam and the federal standard says there is no known medical use, that nothing really concerning either cannabis or in general the endocannabinoid receptor system is covered on that exam. So if we add something like this into these medical students' filled curricula, it means de facto you have to take something else out. And therein lies the conundrum. How do you get this into the curricula when the federal government that determines those exams says that there is no known medical use as their official disposition, even at this moment?
And Dr. Rasque had a question, had his hand up. So I just wanted to.
Yes. Can you hear me?
Yep.
Yes, I can.
Okay. Thank you very much. I commend you for an excellent presentation and a very timely topic. My question is, as far as you know, there's experience in other states with similar educational programs for physicians, the states who have been using marijuana for a while, like Colorado and others?
There are a few states, and only a few states, that have what otherwise would be regarded as high quality education, meaning that it has gone through the process of ACCME accreditation and it's kept current. And the education, as we brought up, is not simply education about the subject matter of cannabis itself, but being educated about what the law is. Each state right now have different laws, and therein lies the specific education that needs to be applied for each state's individual guidelines. There are states that have higher quality education, in particular Massachusetts. There's a state course in New York. But right now, Florida has only a 2-hour course, and that 2-hour course has very little, if any, clinical relevance. Most of it involves the legal advice, and it comes across somewhat as a caveat emptor, a buyer beware, because it is responsible to let physicians know that this is federally illegal.
I want to make a comment, if I may. Dr. Amin. First, I want to congratulate Dade County. It was a fantastic presentation, very thorough, incredibly powerful, and I think it's going to have great utility going forward. So I look forward to it going up to progress and change. I think my comment was regarding kind of why we see this discrepancy in physician understanding, education, and even involvement in this. I mean, clearly, many physicians, if not most physicians, are like sheep and led by fear to more safer pastures. And at this point, this is the same concept of why a headache costs several $1,000s going through the ER with CAT scans and MRIs, unnecessary utilization. We're at that point with this, I think. And so to resolve some of these things, and actually the FSU study showed not just that, but more than that, that religious aspect had a direct implication with why people used it, did not use it, fear, everything else, as you know, Dr. Block. So there are a lot of things, I think, to cross to create the opportunity for physicians to want to partake in this. Liability has always been a huge thing for physicians, like I said. And so with the discrepancy of federal and state, with case studies of physicians being cited or arrested for using medical marijuana, complaints to the board, this and that creates a level of fear and uncomfort. And perhaps because of that, they lack interest in pursuing more knowledge in this topic because they don't see that they're going to be the candidate that's going to be utilizing and prescribing it. And so I think once those fears are taken care of and resolved at national and state level, once those discrepancies are, it's hard to get medical education for a standard of care that's not practiced across the nation, but you have to learn and practice it on individual state, individual county, and it makes it cumbersome, challenging for a medical system to undergo that education. I'm sure that they can create the spot opportunity for that knowledge, but if you're teaching, educating something that's not standard practice and not legal potentially, then it makes it challenging for a standard education across the United States.
Dr. Amini, I want to let I want to make sure we have time for the next presentation. Dr. Fernandez and Dr. Folatier also raised their hands. So Dr. Fernandez, did you have a comment?
Oh, no, I think that the questions I was thinking about were already asked, but I did want to congratulate the group on an excellent presentation and a very relevant topic. Thank you.
Dr. Folatier?
Thank you. I don't want to talk long because I'm about to present. I just wanted to give a quick personal anecdote. My wife has bad ulcerative colitis, total colectomy, the whole 9 yards, and absolutely nothing else worked. And she went through the process of obtaining her medical marijuana card because she's a medical professional and she wanted to do things the right way. And I got to tell you, it is extremely expensive to do things the right way. And so I think that as we continue to address these issues, we're going to have to address the disparities in healthcare as well, because it's not really fair that only people that are well off should have access to these potentially life-altering treatments. And so that's a little bit about what our presentation's about. And I know it's been a theme of a lot of our meetings over the last year. I just hope that as the legal ramifications get worked out and with all the hard work you're doing, that we're able to offer this not just to people that can easily afford it, but people that maybe can't afford it as well.
Thank you for that comment. That's, I never knew that it was expensive to go through the process. So that's interesting to me.
Very. I mean, I'm talking, she's probably already in for $500. You have to renew it every 7 months, which is a kind of a weird time frame. And that's not even the cost of the product. That's just the red tape. So not a cheap treatment.
The cost, Karen, just to answer from the presenter's view, the cost of that program is what it is. The cost of the black market alternative to deriving it, as I showed through the vaping slides, being contaminated products, may be even greater. So
I absolutely wholeheartedly agree. And I don't want people to be driven to black market products because the pure products are unaffordable. I completely wholeheartedly agree.
Mm-hmm. So my comment is not undermining industry, but industry does provide a quality control product that the black market doesn't.
Of course.
So I just want to mention before we move forward, we do have several people. We would love to have everybody be sharing their cameras. I want to make sure people understand that for the CME